Hello, and thank you very much for the invitation to speak today about the allergist role in EOE. I'm an allergist, I'm based in Queensland, Australia, and I do research at Griffith University. I'm going to talk about the components of EOE, why EOE occurs, and what an allergist brings to the table in the management and investigation of EOE. As we know, eosinophilic esophagitis is an increasingly recognised cause of obstruction or dysphagia, difficulty swallowing, and heartburn that occurs in both children and adults. The more we look for it, the more we see it. Diet and reactions to foods seems to play a role in both children and adults. This is a relatively new disease, only described 28 years ago in a case series of 12 patients by Atwood in 1993. The rate that we recognise varies between 1 in 1,000 to 1 in 2,500, and it is rare to improve by itself. Kelly and Sampson identified that foods, putting somebody on a hypoallergenic formula, caused resolution of the number of eosinophils in the esophagus to improve. Food is involved, as it mentioned, and IgE to foods, when we do skin prick testing, we don't see it that much in general practice. But in specialist units, we find anaphylaxis present in 5 to 10% of patients presenting with EOE. And in my practice, when we had a look at the patients, and that may reflect patient preference in referral to me with EOE, we found 24% of patients had a history of severe food allergy and anaphylaxis. There is various evidence on the value of patch testing for foods, and the question I'd like to address, are we looking in the wrong place, I'll discuss towards the end of the talk. I'd also think we're starting to get some information both from patients, patient support group gathering information, scientists, gastroenterologists and allergists. By getting together, we're actually getting some great information about why EOE is occurring. This is just a slide showing high number of eosinophils on the left side and the improvement with putting a child on a low food allergen diet, a hypoallergenic diet on an amino acid formula, showing foods can be involved in EOE. We actually created a summative story of foods. We put the cumulative size of skin prick tests to common allergens involved in EOE: milk, egg, soy, wheat, fish, and nuts. And as you got older, we showed less IgE sensitization to this. We certainly showed patch testing also seemed greater when we reacted, and this is the grade of the patch testing to the 5 most common foods we patched to test for, which was milk, egg, soy, wheat and corn. And then we looked at the inhalant allergens, and we found as patients got older, we more likely to see IgE to inhalant allergens. So this is our picture that we have of IgE with food seem to be important, but we know that food reactions is important in adults, so this model is somewhat wrong. We certainly see food allergy present in older patients as well with EOE. Now, an empiric diet that takes out of foods, most common for foods, is Calaguella's elimination diet, and Amir Calaguella found that by reducing foods in patients' diet, there was an improvement in both children and adults. This was done by a retrospective analysis, which meant he went back and asked patients after they'd chosen to either go to swallowed steroids or take foods out of their diet, and he analysed the result of that. There is some bias in that they weren't randomised. So patients who'd already tried foods out of their diet and didn't find that it worked were more likely to try a steroid, and vice versa. If they'd tried a food out of their diet and felt a lot better, they were more likely to go down the treatment route. So from this 6-food elimination diet, people have actually done 8 food elimination diets, 4 food, 2 food, and even 1 food. And studies at Philadelphia has found that milk was 18 times more likely to reinstigate EOE as any other food. Just about taking any food out of the diet, if you take a food out, you need to substitute it. You need a plan for reassessment and challenge. And there's risk of many people, such as doctors, dietitians, your GP, your allergist, your gastroenterologist, family and friends telling you to take foods out of the diet. So you need to be careful about taking foods out that you may not need to. That can cause expense, nutritional deficiency, and poor growth. When we're having swallowed steroids with EoE, we want them to thicken up so they remain to have contact time with the gullet. Splenda does not thicken things up much at all and actually tastes quite disgusting. Honey can thicken things up. Tapioca can do that as well. Gloop is a commercial product here in Australia. Apple sauce is used in some centres. I don't like it because it's actually quite acidic, and we know that acidic compounds can damage the epithelium, so I tend to prefer Gloop or some other viscous product. I also encourage people to do this just before they lie down, because when you lie down, the esophageal transit time for a contrast diet we know is doubled on lying down. We also get patients not to eat immediately after they have their swallowed steroids. The management plan for EoE exists from ASCO and is available on our website, both for acute impaction as well as chronic management. And we have the cornerstones of EoE management being proton pump inhibitors, steroids, and diet. I'd like to really point out the fact that, like a lot of medicine, proton pump inhibitors and steroids are both band-aids. They hide the disease. Diet prevents the disease from occurring. Paying attention to the allergic health is somewhat a combination of these events. We actually, while we use medications to create a band-aid, we also identify allergens and help prevent exposure. And I have the direction signal there to turning away from allergy, and we can redirect the immune system if we address that. And one thing that we underdo in medicine is think about total health, and I'll just dedicate one slide to that at the end because it's really an evidence-free zone in EoE, but it's something that just makes sense that we should all be thinking about as a big picture in health. Mishra did some lovely studies with a group out in Cincinnati looking at putting allergens in the upper airways and showing that challenging with allergen from dust mite or aspergillus in mice could cause EoE to develop. If they did knockout models, they didn't develop EoE. And by using allergic treatment, we can actually essentially avoid, which is our sort of band-aid model. We can, our sort of knee guard model, we can use medications as a band-aid for allergic disease, and immunotherapy is a bit of a redirection of course there. John-Gert Blunstall in the Netherlands did studies looking at challenges with allergens in the nose and in the lungs. And when he did this, he found the presence of eosinophils rose. They rose in the bloodstream, they rose in the nose at the site of allergen challenge, and they rose in the bronchi. If we think about our embryology, our anatomy, and many of you who are scientists will be aware that the lungs are actually an outgrowth, a bud that grows out from the primitive gut. So our immune system and homing mechanisms for eosinophils, for stimuli, it is not surprising that airway allergens may provoke inflammation in the esophagus. Going back to Gert studies, it was actually replicated in animal models. We usually do animal models first and then confirm it in humans, but it was confirmed a couple of years later. There's a model that exists that was discussed that where we put an allergen in the nose or the lungs, it promotes bone marrows to release eosinophils. They go into the bloodstream and go to the nose and to the lungs. And we're thinking that this also occurs into the esophagus as well. The data supports this is there is an association of EoE with high pollen counts, and some centres don't even bother to do biopsies at high pollen times. There are rare cases of improvement of EoE with injection immunotherapy. So we stick the allergen to something that somebody's allergic to, from an inhalant allergen such as dust mite or grasses, and we have seen resolution of EoE. We certainly see the opposite as well. People have swallowed immunotherapy and we've seen flare-ups of EoE occur. Another important allergic cell is the mast cell. Now, very little has been talked about this in EoE, but this study from 2020 showed that in patients who have what appears to be resolved EoE based on eosinophil counts, but these patients still have symptoms, the amount of mast cells is important in the biopsies. So patients with persistent EoE still having furrows and rings, they're more likely to have higher mast cells, and low mast cells per high power field predicted clinical remission. To getting all the pieces together in EoE, I think we do need to pay attention to all team members, and those include the patients, the patient support groups, the dietitians, our scientists, our allergists and gastroenterologists, and many of these will have crossover roles such as the gastroenterology scientists and allergy scientists as well. There's been some exciting stuff that's happening now when we all get together. This study done in 2018 in the Netherlands looked at injecting milk into the esophagus. We use skin prick tests to look at what we think is happening in the gut. It's a proxy for what's going on. It is not an absolute indicator of allergic response. As we see here, as we patient negative on skin prick testing, but when we inject a small amount into the esophagus, we get massive edema, swelling that occludes the esophagus. But the next day, when we have a look, when the researchers had a look down, there's ulceration, and it is rich of eosinophils. So this may be a method that gets evolved in the next few years, hopefully with microendoscopies, hopefully with several micro injections that we can do several things at once and identify several foods without mucking around with many endoscopies, many days in hospital, many months off foods that we may not need. This is just showing the following day the ulceration and the site of injection. Collectively, through patient studies and scientists, gastroenterologists and allergists, we do have a bit of a background picture of the epidemiology of EoE. It's more likely to occur in urban areas. If we wipe out the gut with treating Helicobacter, as we have with our frequency of antibiotics, we certainly see more EoE. We're more likely to see EoE with early caesarean section and early life antibiotics. PETs appear to be protective. Tryptase is a mast cell compound, so if you've got more tryptase, you're more likely to get EoE. And 1 in 30 patients with EoE, or 33 patients, have connective tissue disease. So that seems to be important. That appear to be involved in EoE. I don't expect you to remember all of these, but it's coming together in a bit of a nice story. So we have protease genes that dissolve things. And a common protease that you might use in your home is papain from papaya, which is a meat tenderizer. So think of that dissolving the esophageal lining and making it more open. Conversely, we have compounds called antiproteases that block the proteases, and we've got several antiprotease gene defects that seem to increase the risk of getting EoE. We have adhesion molecules, things that hold the skin together, and if the skin or the epithelium of the GI tract is not held together well, it will leak more and food allergens will get across there. And inflammatory responses, alarmins which cry out that there's damage, there can be inflammatory responses to that. So a loss of function of TSLP seems to be protective against developing EoE. Eotaxin gene defects a mutation in this seems to protect against EoE as well. Put this into a visual summary with problems with proteases and antiproteases which influence epithelial integrity, but they also are involved in engaging inflammatory responses, and with inflammation this influences antigen processing tolerances, as does the epithelial integrity. And so these feed back into themselves and create quite a complex network. You can put in the genetic factors into that, and it creates quite a confusing gene environment, so that we have many factors at play that can be involved, and we're trying to unravel this. Ultimately, not every case of EoE is the same, because not every case of EoE is caused by the same mechanism. From an allergy point of view, how to treat. If you've got a fire, stop throwing the fuel on. So identify the cause where possible, treat the allergic health, which is where allergists are currently missing out of that picture. In many cases, we're just giving PPIs, proton pump inhibitors, or steroids, which are great medications, but not without side effects. A trial of PPIs are often encouraged, and there's definitely there's PPI responsive EoE, more so in adults, but there's a cost of PPI. PPIs, just on script, even of $500 a year. Swallowed Pulmicort, which is commonly used, or swallowed steroids, again, $40 a month can quickly be $500 a year. And if it's because of dairy, and we can avoid dairy, that's an expense we don't need to have. Trialling off the dairy is the most effective treatment. 11 out of 15 patients in a small study could actually tolerate baked milk. Eliminating several foods and then pulling back is one way of doing this. Swallowed steroids with a thickener is very useful, and we can use combinations. And back titrate, get control on back titrate. I'm very keen on, if people want to have a holiday, because people get sick of being off foods completely. So if there's a special event and a child whose EoE flares up with dairy, let them have a bit of ice cream at a birthday party a few times a year, and do a rescue with a steroid slurry for a week afterwards, or even on the day before and a week afterwards. Uncharted territory, but it seems sensible to have a bit of a compromise. Now, we do need to endoscope and re-endoscope as well. How not to treat is to leave it alone. There is a high stricture rate occurs from leaving it alone, and 70% of patients with undertreated EoE will have a stricture. Do not remain on the same dose of steroids. 75% of people can tolerate a dose reduction. And as I highlighted in one of the earlier slides, think beyond the esophagus. Think of total health of the patient. Make sure we get great sleep, and sleep hygiene, regular habits, regular sleep times, dark rooms, eat in daylight hours, avoid electronics in the bedroom so that we get great sleep. We make antioxidants, anti-inflammatories in our sleep. We know that if we have a poor sleep, the dose of allergen to initiate an allergic response can be halved. Think of nutrition and micronutrition. One of the easiest micronutrients is vitamin D. We know that vitamin D levels seem to affect asthma. We know that low levels of vitamin D, or mast cells, which we mentioned earlier, will break open easier by both IgE and non-IgE mechanisms. Exercise certainly affects neuroinflammation, and we should all be doing at least 3 hours a week. And our headspace. We're aware that stress can drive Th2, which is allergic inflammatory responses. So getting our total health needs to be part of our story. So with that in mind, I'd like to say thank you very much, and I hope you enjoy the rest of the sessions, and I look forward to hearing what the other speakers have to say.